Afternoon, and thank you for joining us for this month's Health Policy Grand Rounds from the Philip R. Lee Institute for Health Policy Studies. I am very excited about our speaker today. It is Monica McLemore, who is the Shelma Shobe Endowed Chair in the School of Nursing. She's an associate professor with tenure in family healthcare nursing and is also a research scientist with Advancing New Standards in Reproductive Health, or ANSWER, here at UCSF. She has been a world-recognized expert in the reproductive health space, particularly focused on equity and social justice. She has a number of roles that I could hardly even begin to explain, but she also is a prolific publisher, has testified has been involved in amicus briefs to the Supreme Court, has spoken with many, many journalists, has been involved and consulted with the National Academy of Science, Engineering, and Medicine, and has done just any number of things that are all described in her bio. I don't want to take away time from her presentation to go through all of it. I do want to also briefly introduce Sarah Garrett, who is one of our Philip R. Lee postdoctoral fellows. And she is doing her postdoctoral work on reproductive health justice and equity issues. She will be moderating the question and answers today. So you will get to meet Sarah as she does that later in this presentation. And we are really happy for you to get a chance to see the great work and some of the thoughts of one of our wonderful Phil R. Lee fellows. So Monica, I am handing it over to you for your presentation. Thank you for agreeing to do this.
Thank you for having me, Joanne. And I am just such a big fan of your work and your leadership, as well as the Philip R. Lee Institute for Health Policy Studies. So it's a real honor to be here with all of you. I also am very, very lucky to have been asked by Sarah, whose work is going to be really, really innovative and potentially game-changing, to work on her work as a case scholar, fingers crossed, to really look at the transformation of healthcare and healthcare institutions, particular to perinatal health. So I'm very excited for this discussion and conversation. For the people who know me, I want to say a couple of things before I get started. You do have my consent to live tweet, to use social media. I'm a big fan on myself everywhere because I think it's really important that science communication really encompasses merging science and sort of helps to normalize this idea that, it replicates itself and builds upon itself. And that what I may present today hopefully will spark some conversation and some interesting discussion here or anywhere else. I can't see the chat, so using that won't be helpful. But again, please use the Q&A. Sarah will be fielding those questions. And you have my consent to screenshot my slides and to really be able to engage in the discussion. Before we begin, I'm a big fan of language. I use she and her pronouns. I think it's really important that we're very clear in terms of how we like to be referred to. In addition, that I'm going to talk about reproductive health, reproductive rights, and reproductive justice. I think I've saved quite a bit of time for questions because I know this topic is hot. I know a lot of people, have tons of questions about what's going on. But I want to be really, really clear in the field protections that really afford us to operationalize, our rights as citizens on this planet and in the world. And so I'm talking about legal protections and other pieces of policy that I think are relevant to this audience. So that said, I'm going to be spending a lot of time in the reproductive rights space in my talk. Reproductive health is reproductive health services. For those of you who know me, I spent 28 years in active clinical practice, the last 18 at Zuckerberg San Francisco General Hospital. I worked at Kaiser, I worked at Stanford, I worked at the Haight-Ashbury Free Clinics. And right now, my only clinical work is providing COVID-19 vaccines and influenza shots to individuals with the Umoja Project. I think a lot of you know Kim Rhodes and her amazing work at the Cancer Center. Reproductive justice is a completely different framework, and it really stipulates that reproductive oppression is the root cause of a lot of health inequities, and it's really connected to social justice and human rights. And it's the human right to be able to give birth and to become pregnant in the circumstances under which individuals choose to do so, and have all of the social and community supports in order to be able to do that with dignity. It is a human right to not become pregnant or to prevent pregnancy or to end pregnancies with those same social and supports that are necessary in order to be able to do that with dignity. So right to parent the children you already have, whether you're an incarcerated person or you're a person whose children are wrapped up in the foster system, if you want to be an adoptive parent, or if you're going through infertility, it is this whole idea that you have a right to parent the children that you have, if you are disabled or differently able. And finally, it is a human right to disassociate sex from reproduction. And so we can have honest adult conversations about consent, about healthy sexuality, about pleasure, about menopause, and a whole variety of other conversations that I think can be encompassed in a reproductive justice framework. So I will intentionally be using these words specifically, not only in my language, spoken language, but also on my slides. A lot of you are probably confused or curious about my multiple hats. And so I, as an affiliated member of Philip Barley, which I'm very, very proud of, I wanted to also let you know where my program of research and my projects sort of sit in the broader context of really understanding why do you run a pre and a postdoctoral program that's specific to reproductive health, rights, and justice? Well, part of it is to bridge some gaps between the School of Medicine and School of Nursing. Part of it is also to really think about the research gaps in terms of how things get carved up into departments. So you have people who have clinical research careers, you have people who have basic science research careers, you have people who have, nursing careers, you have public health. Our program encompasses all of those things in addition to community engagement. So if you look at our legend, you will see that the Philip Barley Institute for Health Policy Studies is an active research partner with the actions program that I direct. And it has to do with, workforce initiatives and things that Dr. Spetz and I have talked about for the last decade, and really wanting to ensure that we have a future workforce that represents the people that we serve, in addition across the reproductive spectrum. So with all of that, some caveats in the next 15 or 20 slides I'm going to show you. I have a purposive focus on the United States. That's where most of my work is grounded. And it's really a hotbed right now for reproductive health, rights, and justice, especially when we're talking about abortion and its access or lack thereof. And so I'm unapologetically going to focus on the United States. I've already provided you active and proactive consent to share my words and my work. And I am going to talk a lot about abortion in my next couple of slides, as well as the state and federal Omnibus, given the legislative activity and how rapidly things are changing. I also am going to talk about statewide initiatives in California, but I'm also going to talk about the states that we want to keep our eyes on. For people who don't know, the Bootmaker Institute has been around for the last 50 years doing rigorous evidence-based science. They're located in New York City. And they've been gathering statistics on abortion, family planning, and contraception, and reporting those statistics to the CDC in partnership with other public health measures like BRIFIS and PRAMS, the Behavioral Risk Factor Survey, as well as the Pregnancy Risk Assessment Monitoring Tool. They've compiled statistics for a long time. And what we learned in 2017 is something that we knew was trending, but it actually was really confirmed by data to really show that abortion is increasingly concentrated among poor women. And this is really, really important because it has implications for when we want to talk about health equity in terms of, really understanding how abortion is accessed, how it's paid for, and how people are able to utilize services. It also bridges this discussion between that the bulk of abortion provision in the United States is provided by clinics, and most of those clinics are independent. So they are not, academically affiliated clinics like we have at UCSF and other academic institutions. It's not Planned Parenthood. The bulk of abortion care is actually provided by independent abortion clinics that are operated by owners in either for-profit or nonprofit systems. And full disclosure, I sit currently on a sabbatical from the Abortion Care Network Board, which is the membership association for those independent clinics around the country. The other thing we learned in 2017, and current data are no different. I was just at the Society of Family Planning meeting that happened in October, and a lot of you know that earlier in October, and a lot of you know that the American Public Health Association meeting begins tomorrow, some of the content. And I've seen more updated data that are yet to be published, but they look very similar to this. The abortion rates continue to vary by race and ethnicity. And when you look across race and ethnicities, there are no majority of abortion patients. But when you group Black, Indigenous, people of color, you do see that there is a larger proportion of Black, Indigenous people of color who have abortions in the United States. than their numbers in the population. This has not changed, but like I said, the new data that have been updated are not yet published. They are still under peer review, but they've been presented at the Society of Family Planning meeting, and I know that there's some content that's being presented at the APHA later on through the weekend and next week. Oh, and full disclosure, I'm the chair of the Sexual and Reproductive Health section for the American Public Association. This is a new slide. It was just posted on the Bootmaker website, and I put this up to say that, you know, if you look at 1973 on this end, all the way until we get to now, there have been many more abortion restrictions that have been put into place, and this year is actually on target to top any other year in terms of the numbers of restrictions that have been enacted. And this goes to September 17th of 2021. And I always put this slide up to say that a lot of legislative activity is around reproductive health rights and justice. And yet we don't see that same level of activity around, you know, jobs bills or paid family leave. Or when we think about even the Omnibus, when we think about this, that there have been more abortion restrictions than family supportive policies or policies that we know would get us to health equity ever since Roe was settled law in 1973. And so in this year, I really tried to narrow this talk, but if I really wanted to talk about even just abortion, I have very limited time to do so because of the amount of policy and legislative activity that has been going on. So I'm going to just give you a snapshot, a very high level view of where we're currently at. And I'm going to use my words to try and link it to why it matters, like things like voter suppression, like paid family leave, like the sort of stalled Build Back Better agenda that's currently languishing in the House and the Senate, really trying to get those numbers to a place where it actually can be as impactful as we would like it to be. But many of the things that are looking to be truncated, if you were listening to KQED this morning, are those things that we know that will move us closer to health equity across the reproductive spectrum. And so that's been relatively frustrating. That said, many abortion restrictions that abound are those that are directly linked to health equity. So when we think about waiting periods, and we think that even in COVID-19, people don't have paid family leave to quarantine and to isolate themselves, when you think about the fact that people don't have paid sick time, taking time off from work, these are very similar to the ways in which abortion restrictions have been operationalized to really make this difficult. The 2-visit minimums, this mandatory ultrasound provision and viewing, which is not evidence-based, the codification of non-evidence-based practices into laws. I'll talk a little bit about this when I get to SB 8 in Texas. And sort of some of the drama that's been going around within the reproductive health provision space. When you think about physician-only laws and how we could expand access to clinical services, not just abortion, but when you think about the work that midwives could be doing and have been doing through the pandemic, has implications. I always say that the canaries in the coal mine for many of the restrictive policies that we see that will not get us towards health equity are actually grounded in and have been tested in abortion space. So when we think about why we can't upend some of the things that we know that will move us towards health equity, all you have to do is look at the abortion playbook to really understand how we got here. And that also includes misinformation, as well as the individuals who participated in the January 6th insurrection. I know that many members of the independent abortion clinic providing community were able to provide photos and cross-reference profiles because many of the insurrectionists had also been participating in abortion clinic protests, as well as violence against abortion clinic. When we think of the hallmark landmark of that this year, that the Build Back Better agenda was the first bill since the Hyde and Helms amendments were added as riders. This is the first time we ever had a budget bill that was introduced that did not have Helms and Hyde on it. It's a big deal and speaks to the work that All Above All, which is an advocacy organization based in Washington, D.C. that has been doing to try for the last 20 years to get a bill introduced without Helms or Hyde, meaning that public dollars could not be used at the state level for abortion access, except in the 33 states where it can only be in life endangerment, rape, and incest. The reason I told you that abortion was increasingly concentrated amongst poor individuals and that it was mostly around Black, Indigenous, and people of color is because they disproportionately represent people who use public insurance or Medicaid as a primary payer for pregnancy-related care. That's how these things are linked together. It's not just that we want to willy-nilly be able to use public dollars to be able to fund abortion. We can have that ethical conversation, while we also can admit that taxpayers are not inclusive of rich people. And then in fact, low-income individuals and poor individuals actually also are taxpayers and should have some say in how their tax dollars are being used, especially when it comes to health services provision. I won't go through everything on this state, but I will tell you these are the caveats and nuances of when and where and how public insurance can be used for abortion provision. And that's why it was such a big deal that Helms and Hyde were not part of the budget negotiations. It looks like that may come back onto the table as part of the negotiations to bring down the dollar amount. But again, this is all in flux. And what I may tell you today might change tomorrow because my slides are already wrong. I can tell you about what happened in Texas, in specific to SB 8. So I'm going to do this by losses, but I'm also going to do this by gains. We always want to report the potential losses that we see in reproductive health rights and justice, but we also don't own the gains. And we've had several gains that I think are really important to point out, especially in the context of health equity. So SB 8 is the onerous and egregious and what I think is an unconstitutional law that was passed in Texas. I'll show you a timeline around that. That really not only basically banned abortion in the state of Texas at the 6-week mark of pregnancy recognition, but it also, for the first time, deputized other citizens, private citizens, to say if you are aiding and abetting someone in obtaining an abortion, that you could be sued in civil court for up to $10,000 in damages. And this is why, Lyft agreed to pay legal fees for anyone who accompanies someone or drives people to abortion, because we use that quite a bit in terms of people needing a ride back to their respective homes after their procedures. This is why leaders like Mark Benioff and other corporate partners who have headquarters in Texas also stated that they would be able to look at, excuse me, somebody speaking? Would be able to look at paying legal fees for their participants because it's the first time encoded in the law that anyone aiding and abetting someone to obtain an abortion. That also includes the National Network of Abortion Funds, who provides supplemental money, gas dollars, hotel rooms, all of those social supports that are necessary for people who otherwise don't have the income to be able to pay for their abortion, to be able to meet those state mandates. Florida, 3 days after Texas introduced SB 8, Florida introduced a very similar bill. And that bill was working its way through their administrative or their legislative process. And the governor has already said that Rob DeSantis said he will already sign it. And then in Mississippi, we have a pending abortion case that could overturn federal Roe. It will be heard by the Supreme Court on December 1st of this year. And it really, really is looking at the 15-week limit to abortion provision and really looking at viability, which for listeners on this call, if you did not know, viability was the compromise that Thurgood Marshall, the first Black Supreme Court justice, was able to really negotiate when Roe was being adjudicated through the courts. And a lot of people don't know the backstory because we don't teach comprehensive Black history, but he and his wife had suffered through multiple miscarriages while they were trying to become parents. And he always knew that the science would always outpace the law. And so one of the reasons that viability is not a number in the way that we think about it in legal circles is because we always knew that number would decrease as scientific discovery would increase. So it was this very prescient place where a Supreme Court justice who had been a lawyer with the NAACP had enough clinical and healthcare and scientific knowledge to appreciate the fact that viability shouldn't have been a number, in the 1960s and 1970s when these cases were being adjudicated, because he always knew that the science was going to surpass the law. So it's another place where the evidence that we collect, we want to be really strategic and really aware when we report our findings, because they will have, impacts over time. And we want to really make sure that our law friends, our, policy friends, our lawmaker friends, sort of really understand the ramifications of our scientific findings and that we can communicate them to them clearly so they understand the long-term impacts of these pieces. So let's stay with Mississippi for a little bit, because this is another place where we're seeing a win, right? For the first time ever, there is a historic amicus brief that I co-led with the National Birth Equity Collaborative that actually is the first, to our knowledge, to make a human rights argument to state that human rights trump states' rights in the context of Mississippi, that bodily autonomy for pregnant capable individuals trumps any state's interests, either in the pregnancy or the fetal possible personhood, or in peri-viability. It was the first time ever that a unapologetic human rights, argument has been made to actually really trump the states' rights piece, and particularly on behalf of Black birthing people whose, previous reproduction was basically used to build out, the economic engine of this nation, if you think about enslavement as such. This was also the first case where 500 women athletes talked about the value of the need for bodily autonomy, again, tying together these very crucial concepts that Serena Williams talked about in her near-death experience during her pregnancy, that bodily autonomy, these are people who are paid to really have their bodies function at the highest level, right? Their livelihood is contingent upon the optimal physical conditions and the fitness that they have. They told their abortion stories around how it enabled them to participate not only as full members of athletic teams, but full members of society. And if you have not had a chance to read an amicus brief, I highly recommend that you do. There also was a reproductive health rights and justice scholars briefs, in addition to public health briefs. And it's really important that we keep our eye on the Dobbs versus Jackson case, because for the first time, it will allow for static science to make a determination about limitations on human rights and bodily autonomy. And I always say, right now, the law of the land is you have bodily autonomy in life and death. No one can go dig up your remains after your death and be able to harvest your organs without your consent. And this is a really important topic, regardless of how you feel about abortion. It really gets to this larger notion of who has standing, who is an arbiter, and what human rights are able to be operationalized, and where can states' rights trump that. We've also had a lot of legislative wins. My home state of New Jersey passed an advanced practice clinician expansion for nurses, nurse practitioners, and nurse midwives to be able to provide abortion care. They removed physician only this month. And so it was very, very good to be able to see that the ACLU, the Lawyering Project, and a lot of other legislative, a lot of legislative advocates have been working behind the scenes to make sure that abortion services can be shored up and in fact expanded to meet the needs of the people that we serve. And so Governor Murphy actually signed that bill into law. Glad to see that. In a case near and dear to my heart, in Virginia, we also saw removal of a whole lot of targeted regulations against abortion providers, including waiting periods and advanced practice clinician expansion. We are seeing nurses being able to have continuity of care, midwives being able to care for patients across the reproductive spectrum. We know that improves trust. We know that it improves the patient-provider relationships. So for people to have continuity of care is really important. Study from the Health Workforce Pilot Project was also cited in Hawaii, where people who are on the islands that are, not Kona, that's not the big island, they have been having to fly or take a boat to be able to receive medication abortion because advanced practice clinicians have not had the practice authority to be able to provide that. And the expansion of Hawaii was a perfect exemplar to really understand why medication abortion and telehealth provision of medication abortion should be provided, because of their geographic sort of issues in being, an island state. In South Carolina, we saw the Fetal Heartbeat Protection Abortion Act be defeated. Again, these are unconstitutional laws. It doesn't, just because they're unconstitutional, at least now under federal law, doesn't mean that it still doesn't cause a lot of legislative activity. It doesn't cause a lot of need for evidence-based policy and a lot of education for policymakers and staffers. We're keeping our fingers crossed. We have our eye on Minnesota. The Lawyering Project has been doing a lot of work to upend a lot of targeted regulations of abortion providers there, including advanced practice clinician provision of abortion care. We had some Jane Doe clinicians who really wanted to speak up around not being able to provide comprehensive reproductive health services, especially in the more rural parts of Minnesota. And so we have until, I'll find out on October 31st if I'm being deposed in that case or not, because I served as an expert witness to provide data and evidence to show that advanced practice clinicians could safely be provide medication and aspiration abortion in the first trimester. And then we saw an incredible partnership between the National Association for the Advancement of Colored People, the NAACP, and the National Advancement for Asian Pacific Islander Women's Health Forum. We saw a great collaboration to strike down race and sex selection bans for abortion in Arizona, really making this case that, again, pregnant people are the experts by experience, and they are the best people to determine what they need in their lives to be able to optimize their reproductive life course. So we've actually had some incremental wins that I do think we need to take credit for, because when we're constantly looking at federal role as the metric or as the touch point, we miss all this sort of incrementalist change that is really helping to widen the human rights frame of people to be able to optimize their reproductive autonomy. So I do want to talk a little bit about David Delight and Whole Women's Health. A lot of people don't understand that in Superior Court in San Francisco, he was actually indicted on all the charges where he illegally not only recorded and taped abortion providers at annual meetings, but then also doctored those videos. There was a permanent injunction that was obtained by MoFo, thank you, Morrison and Forrester, a San Francisco-based law firm who actually really took this case on, and he has been indicted along with his co-collaborators and conspirators for those doctored videos that came out about Planned Parenthood and the sale of fetal body parts. So that is another one if you were not aware of it. And then, of course, we have Whole Women's Health versus Hellerstedt, the case that was argued successfully in the Supreme Court in 2016, where, we really saw, Stephanie Toti, and this is the second youngest lawyer who ever argued in front of the Supreme Court. The first was Sarah Weddington, who argued Roe. She and her team at the Lawyering Project have been proactively going around the country to look at which states would have trigger laws that would revert back to abortion being criminalized if federal Roe fell. Meaning, if after the case is heard on May 1st, specific to Mississippi, and if peri-viability becomes a reason to actually ban abortion at prior to 15 weeks, Mississippi, and it has a direct challenge to federal Roe, then where are those states that have automatic trigger laws where abortion would again become criminalized, and where can we upend those laws and do some proactive lawyering using Whole Women's Health as the current standard to be able to remove that undue burden? So she and her team have been going around along with members of the ACLU and the Center for Reproductive Rights, as well as the If, When, How Lawyering for Reproductive Justice group, to really shore up that there still will be state access to abortion in those places that geographically can serve a broader range of individuals, so that the language that we use around, federal role falling, I think we want to be a little bit more nuanced and try to curate different conversations about that, because there is some proactive work that is happening. I've already talked about this all above all. This is the website that they have to be bold and end, hide, and Helms to lift the ban on Medicaid coverage of abortion. And fingers crossed, right now we do have a federal budget that's been introduced with neither, and that is to be celebrated. We're still celebrating AB 154, which removed physician supervision from provision of abortion care in 2012. And for people who missed it during the pandemic last year in 2020, Governor Newsom did sign the bills removing physician supervision from nurse practitioners and nurse midwives in the state of California. So we can be really, really, excited that we'll see some new movement and some new activity around advanced practice clinician provision, not only of abortion, but comprehensive reproductive health care and, gender, affirming care as well. People told me as a pre-tenure professor that I was going to ruin my career if I decided to be on abortion-related billboards to support NIFLA versus Becerra, when Javier Becerra was our attorney general and arguing the California Reproductive Fact Act. And I would argue, that being on those billboards not only helped to propel a different conversation about what was possible, but that we need more risk-taking investigators to do public science communication to really help the public understand that these are some complicated issues and that we need their thoughts, their insights, their buy-in, their community engagement, that if we're going to try and build towards spaces where we can have full reproductive autonomy across the reproductive life course, we're going to need more partners than just health services provision and the law. We also have a lot of new training providers, new training programs. When we think about building out the science, when we think about building out advocacy, there are more ideas that we have in terms of thinking about, if we really want to use a reproductive justice approach, then how can we bring more people into our pipeline? I found out a couple of weeks ago that there is new interest, new dollars in thinking about expansion of midwifery practice in the United States. When we think about paraprofessionals and doulas, when we think about the workforce that we need, we think about the infusion of money of federally qualified health centers in the American Rescue Plan. We need to have these discussions about how can we do work differently and how can we bring in new trainees and new learners so that we have the workforce in the future that we need to really be able to provide comprehensive reproductive health care. I've talked a little bit about broadening our research agenda. And so I do want to switch to thinking about in reproductive rights, we really need to build the power of women of color, and we need to address this reproductive oppression in this historical context spot on. And I think there's a couple of ways for us to use policy to do this. There's some states we want to keep our eye on. I mean, there's a end abortion deception campaign that's similar to the billboards that I did. There are crisis pregnancy centers cropping up all of Louisiana. And if you've been there, you know some of the big names because they look like health services providers. They look like clinics. And they've been getting state dollars just like Ohio to be able to provide pregnancy counseling, pregnancy options, care. And so using the same hashtag we used for the billboard campaign, the End Abortion Deception, this is really targeted towards crisis pregnancy centers and other religiously affiliated providers of pregnancy option counseling, but not reproductive health services provision. In Ohio, it is one of the big Midwest states that will trigger back to abortion being criminalized if federal roll falls. So there's lots of conversations about how to shore up Ohio, as well as Indiana. I mean, in Indiana, we've seen some medication abortion reversal and other trap laws, again, that have been blocked by federal appeals courts. But again, a big, sort of Midwest state that has a lot of healthcare providers, but also a lot of health disparities that have implications for health equity and health equity outcomes. And then we saw a whole 360 from the FDA around COVID-19 medication abortion and telehealth, and designating medication abortion services as essential services. So again, keep your eye on making sure we just don't revert back to you need to have an in-clinic appointment to be able to take a pill. I want to switch gears for a little bit for the last couple of minutes and talk about the Omnibus, both in California and the federal Omnibus. For those of you who don't know about these laws, I think they're very important. I'm going to be on a webinar this weekend for the Bay Area Black Nurses Association. And, my shero and fangirl, Rep. Lauren Underwood from Chicago is going to be on that with me. This is her brainchild, along with Rep. Alma Adams from North Carolina. This is still pending. And, in 2020, right at the height of the pandemic, that Tuesday morning when we went to national shelter in place on March 12th, I think it was, yes, they introduced in the 116th Congress 9 bills that were comprehensive bipartisan legislation to really address the Black maternal crisis, but really just maternal crisis in the United States. And it went nowhere because COVID-19. After the insurrection, before the insurrection, because the Congress was sworn in that Sunday before, there was the first thing Lauren Underwood and Rep. Alma Adams, they reintroduced it. So in the 117th Congress, it was reintroduced. Initially, it was supposed to come forward in January after the inauguration. It came forward on February 8th. Again, comprehensive bipartisan legislation. There are 204 signatories to the bill across party lines. And the original bill had 9 bills. I'm going to rapidly go through these, but the Social Determinants for Moms Act really gets at a lot of stuff we've been trying to talk about in terms of housing, in terms of transportation, in terms of WIC eligibility, and looking at environmental contaminants, and really starting to think about, childcare and grants to state, tribal, and local governments to really start some new and innovative programs to be able to look at social determinants of health, and for us to really address them in a comprehensive way. That's bill number 1. The Kira Johnson Act, which is really looking at community-based organizations, looking at perinatal mental health, health literacy, funding of doula and perinatal workers, and really trying to get at respectful maternity care compliance offices. This is Charles Johnson's wife, who runs for Moms for Kira. She died here in California at Cedars-Sinai, giving birth to their second child by C-section. And he's told his story publicly and has been on the Hill, for the last 3 years, advocating for this act. The Protecting Mom Who Served Act. This is the only bill of the Omnibus that actually has already passed. It's for veterans and Veterans Administration, and it's really around mental health services. It's really around childbirth prep and education, access to nutrition. It is one of the most comprehensive bills we have at VA facilities for pregnant and capable and birthing people. The Workforce Act is, I know that there's support for this one, but really trying to look at culturally and racially congruent care, new money within HRSA to really be able to look at the perinatal providing workforce, and really having this tied to the Unite initiative under the National Institutes of Health to really look at our workforce development programs, and to really build out doulas and midwives and physicians and family medicine and nurses and other healthcare providers. The Data to Save Moms Act, I know that there's a lot of activity around this one, specifically for HBCUs. There is a supplement bill that Rep. Warnock is co-sponsoring to also look at HBCU upgraded infrastructure that's historically Black colleges and universities, especially those with health sciences and health sciences campuses, to really foster the data that we need. The Moms Matter Act, this looks like it will get some bipartisan support as well. This is for the maternal morbidity and mortality reviews, committees where we look at every maternal death and try to establish the root cause. There is some supplemental money in the American Rescue Plan for this, but everyone knows the MMRCs really need to be shored up in ways so that we have consistent and rigorous and good data so that we can actually act on those causes of maternal deaths and those more upstream approaches. The Justice for Incarcerated Moms Act, this is a bipartisan piece of legislation as well, to really look at jails and prisons, to look at doula provision, to really study the negative implications of the cutting off of Medicaid coverage for incarcerated mothers, to really look at community home and community dwelling programs that could reduce recidivism, like the doula program I started in San Francisco and Santa Rita Jail with Dr. Carolyn Suffren and our doula colleagues from Roots of Labor Birth Collective, really trying to think about how can we have more upstream and community-based supports for incarcerated persons. The Tech to Save Mom apps, you've seen a ton of new apps and new mHealth products, whether it's Maven Clinic or getting tons of attention from people like Oprah and the Mommies and Mommy app. We've seen tons of attention around apps and bundles and thinking about monitoring and surveillance tools to really help improve maternal health. I would also add in this, there's been a lot of telehealth activity as well, to be thinking about this idea of how can we fully integrate tech and mHealth to really try and think about, the use of technology as a both and, not a either or. Okay, for all of these bills they build on each other, even though they're separate bills. We do know that there's some tolerance to want to be able to get some of these bills done quickly. And so part of that is strategy, right? But they are standalone bills, but they are meant to intersect and to weave and to really think about how we can create a whole constellation of services that will improve maternal health across the reproductive life course. And then there are perinatal demonstration projects that we want to be able to look at, including insurance coverage and payment models. How do we prevent disruptions in care? So then in I'm trying to get away from preconception, but in those periods in between pregnancies and around pregnancies, how can we maintain optimal health for people so that if and when pregnancy does occur, and if and when pregnancy is continued, that people will have the best shot at the healthiest outcomes that they can have, really having that discussion. And then in the new Omnibus, there are 3 new bills. So it includes all 9 of those, except the VA one has already passed as part of the American Rescue Plan. How do we invest in unique programs around COVID-19 and pregnancy to advance respectful maternity care? How do we invest in community-based initiatives around climate change? Right? We already know that, particulate matter and heat exposure, work from folks even at, Philip R. Lee, when I think about, like Deb Karasak's work and Rita Hamad's work, when we're really looking at, these environmental, exposures, these environmental pieces, when you look at the earned income tax credit, when we look at, basic minimum income, these are sort of the new COVID related, how do you add in instead of just usurping Omnibus? We widened Omnibus to really think about how we can promote vaccinations as well for moms and babies. I was excited when California Omnibus came forward. I tweeted about this and said it's not the end all be all, but it's a good start at the state level. Nancy Skinner from Berkeley introduced this, and Newsom signed it into law on October 4th. The call before got on this one was with the consortium of doulas that are really looking at the Medicaid part of reimbursement. That was part of the Omnibus. And we've had a group that has been on a PCORI funded project that's led by Dr. Cassie Marshall, who's at UC Berkeley, to really talk about what's the statewide approach to making sure that equity can be front and center, and that community doula programs can be prioritized in anticipation for this law. And I think, the Black Women for Wellness and Norbise Flint and her team, as well as Amy Chen at the National Health Law Project, who really did a lot of work to consult on this bill, but really operationalizing it and evaluating it are going to be really big areas where we want to be thinking as an institute of opportunities to really, really look at how we can, what metrics do we want to look at that are not traditional metrics to improve not only health outcomes, but also community partnerships, right? If we as UCSF and if some of our institutes becomes the employer of choice for doulas and midwives, if our hospitals and our healthcare institutions can become the birthplace of choice, I think we call that a win. We need that as a sort of interim evaluation metric, as opposed to trying to look at bigger things like, or health outcomes like preterm birth, or looking at, maternal deaths, because in order for those to move on a population level, we have to have really good metrics in the intermediate and in the interim areas to really look at what's that roadmap that got us to that population level reduction. So with that, I'm gonna stop sharing my screen. I see some questions in the chat. I'm happy to talk about anything I did talk about. I'm also happy to talk about anything I didn't talk about. And Sarah, are you available to come on board? Hey, there you are. Please, let me know what you got for me.
Thank you so much, Dr. McLemore. This was an incredibly informative talk you gave, and I think inspiring as well, especially given you've focused on ways for us to look for progress we've made and opportunities to make further progress. We have one question in the chat, which I will speak to, but I'd like to invite anyone with questions. Please don't raise your hand in Zoom. Please actually type your question into the Q&A box. So we will process questions as they come in there. So Dr. McLemore, one question from Dr. Catherine Phillips at IHPS writes, these issues are so emotionally charged that it often seems that the science and evidence are not considered in the policies. This discourages those of us who are researchers to do empirical studies. Do you see ways to overcome both the lack of attention to science and researcher burnout as a result?
Oh, that is a huge question, Dr. Phillips. Thank you so much for it. And it's an important one. This is one of the reasons why having community engagement to your work is so important, because community-based organizations and community engagement, they will push in ways that we can't, right? One of the reasons why I think the California Omnibus was so successful is because Norbise Flint and her whole team there are evidence-based folks. I know a lot of y'all know them, right? They pulled in the March of Dimes. I was just on a call with my Shariki and her team, right? They pulled in the California Doula Alliance. They really pulled in the Health Net folks. So I don't think we can do this as individual researchers, but a sure way to get burnt out in doing this work, because you're absolutely right. These are big constructs. These are huge things we're all trying to deal with. We got to do this work in community. We got to do it in partnership. I said this on a webinar. I was the keynote speaker for Society of Medical Decision Making on Monday, and I said this there. I will say this here. We need a human genome scale approach. If we're looking at health equity, especially in maternal child health, if we are looking at reproductive life course, we need an intervention and a research engine that's on the scale of the problem. And I think as half the population, if we think about uterus having individuals, and I'm purposely using reproductive justice language, but I also think we don't want to exclude people who produce sperm. If we really want to look at a phenomenon that impact half our population or more, right? Because we do know that, it's estimated between 50% and 75% of our population will parent at some point in their lives, whether they're their biological children or not. If we know that, then we need to think about who are the partners that we need to bring into our research studies. So we're not just trying to get to policymakers and say, hey, but the data show, the evidence show. We need to bring on board the barbershops. We need to bring on board the funders. We need to bring on board the public service announcement and the news media. We need to bring on board the public and the taxpayers, right? So the question is about, people ask me how I do so many projects and how I have so much work and how I'm not burnt out. I don't do this work alone. And when I do it alone, that's when I know I'm frustrated, right? That's when I know I'm not doing the best work that I can do, right? At UCSF, we've been trying to really leverage, the CMQCCs, the California Maternal Care Quality Collaborative. We've really been trying to pull in the preterm birth initiatives. We've really been trying to pull in, and I know a roadmap is coming that Dr. Kamara Jones is pulling together as our UCSF presidential chair. People forget that she's a physician in addition to being a public health person. And she started out in the maternal child health work because she's trained as a pediatrician, right? We got a whole roadmap of all the different stakeholders. We need to involve tech. Shoot, I talk to venture capitalists all the time about this work. They can pull levers way easier than we can, right? How many people, this is one of the reasons why the Baby Dove initiative is so important. If you don't know about that, the badass Black women at Dove convinced Baby Dove, which is a line of products, they have babies, to put up to $1,300 for a doula for any birthing person, with a prioritization on Black and Indigenous people in the United States. They have a birth justice fund with a less than 1 page Survey Monkey application where people can get doula support around the country. And they are matchmaking with community doulas on the ground. They are paying for doulas for birthing people, right? Or when you think about, I'm on the board of Clio, which is an app that one of our alums, Chitra Akansaya, runs, right? How are we matching community-based organizations with birthing people on the ground in their community and then paying for that? How are we using healthcare spending accounts and matching those so that people can get the care that they need, right? I want a Toms of Maine model to see when we're going to ask our corporate friends to pay into a public fund that can match healthcare spending accounts for people at a certain income threshold, because that could bolster the good work that we're trying to get done with the earned income tax credit, right? We need to start thinking out the box around some new ways of who else needs to be part of this conversation. That's why I like what Ajin Koo and some of the folks from Time's Up are doing around the care economy, right? Who else do we need to ask? That for me is how we get past this evidence to practice gap or this evidence to policy gap. We're not talking to the right people. We are still navel gazing amongst ourselves. And there are asks. I was on a webinar with the New York Fed talking about how they can start to make strategic investments with their community benefit fund. I know San Francisco has an incredible Fed, community investment fund. And I know that Deb Karasak has spoken there. How are we still talking with the Fed, the federal bank system, to think about health and well-being and to address some of the transportation issues and to look at our civil engineers? Who are having that discussion? Those are the kind, and who is talking with the sports teams? I want somebody to talk to the Warriors, and I want somebody to talk to the NFL. I want y'all to be talking to the sports teams, right? They got partners and spouses and nieces and nephews, right?
And now the Institute is right next to the stadium.
I'm like, yo, they be signing billion-dollar contracts and stuff over time. Seriously? Have we asked them? This is the kind of thinking that I'm gonna need us to really start to seed and to start to think about. I'm sorry, that was a long answer to one question. I know we got other questions, sorry, but.
No, that's excellent. Thank you so much.
What else we got?
I love the out of the box thinking here. A lot of questions have come in. So Dr. Dan Doan, core faculty of the Institute, writes, with so much to do and to be done, can you share how you think about prioritization? How do you make decisions about where to invest your time and effort, and any lessons you can share with folks at IHPS in this regard?
Yep. So I'm unapologetically Black, and I had in my intro, the reason I say that I'm a tenured associate professor is not only I'm the only tenured associate professor in my school, I'm the only Black tenured associate professor on campus. So for me, I focus my attention on a principle that Bell Hooks, who is a Black feminist and prolific writer, brought forward, which is you have to center the margins. Or in other words, the people closest to the problem are the people who are most likely to have the best and innovative solutions. So again, this is why being an accountable to community is really important. That said, I will lift up the work of any Black person, Black student, Black investigator, because I am tired of being an only. And I don't think I'm the most innovative thinker on the planet, right? Now, when I get in community with other Black women, man, we can really think broadly about stuff. So find your peeps, find your tribe. The other thing is we all can't be doing the same thing. One thing that really frustrates me about researchers and scientists is everybody wants to be on team utopia. We all want to be in some aspirational place that doesn't currently yet exist, but nobody is building a roadmap as to how to get there, right? I want more people building the roadmap as to how to get there. Like, here's a perfect example. Doula reimbursement is great, but doula work is built on trade, and it's built on trust, and it's built on the sacredness and the magic. How do we figure that out and do reimbursement at the same time? Reimbursement doesn't work for physicians and other people who are paid that way. So why are we trying to reify that with people who are trying to think about health equity in a whole other way? What are the new payment models that we need in order to think about sustainability for doula work? Somebody got to work on the reimbursement because that's important. But then someone's got to work on the other part. And we need to have more conversation about who's doing which work, right? That's why I like Philip Barley. There are some people who are working at pulling the federal levels, and there's some people who are pushing the state levels. Some people are trying to push the boundaries around our local levels, right? But we need a collective plan around that, not like everybody chase one grant and do this and do that, and hopefully at the end we'll have some patchwork that's going to make sense. I said it. It needed to be said.
Well, sort of sticking with this same theme of figuring out who is doing what work and how can we both support each other and find our place to make sure we cover that landscape. Shira Rutman, also at IHPS, writes, thank you, Monica. Have you seen recent examples of successful partnerships with Native American / tribal organizations / leaders with mainstream reproductive rights organizations? Do you see Native representation in these orgs, or do you see this as an area of opportunity?
Both. And the baddest ass person that I know that's doing Native, Indigenous, and epidemiology is Abigail Echo Hawk and her sister. They are in Seattle, and she's an epidemiologist by training, and her public partnership that she has not only with the Kings County and Seattle Departments of Public Health, as well as University of Washington, is unparalleled. So if you don't know the Echo Hawk sisters, OMG. They are doing some of the most bold and innovative work in reproductive health rights and justice in partnership and in community accountability. So if you don't know their work, I would definitely be Googling them. And they are trying to pull together a model for the Indian Health Service and really trying to work closely to spread their policies, their practices, and their procedures that they've been able to do in Seattle, and they're like Native, Indigenous, tribal leaders, right? They're leading the work. They are allowing, the tribal nation to lead the work. They are doing the most. That's the best I've seen.
Excellent, thank you. Dr. Janet Kaufman at IHPS asks if you could comment on prosecutions of women who have had miscarriages on the grounds that they did things that put their fetuses at risk, such as using illicit drugs.
Oh, this is a whole thing. I talk to Lynn Paltrow at the National Advocates for Pregnant Women about this all the time. In fact, she and her team were representing and I'm blanking on her name, but I'll come to it in a minute. The woman at Chowchilla who was accused of exposing her fetus to drugs, and she was being prosecuted here in California in Chino. I mean, they finally got her case dismissed. The criminalization of pregnant people in the context of drugs is just really shameful. And I think, not only do we need to stop locking up pregnant people, but we need to stop criminalizing drug behavior, right? So this is where, again, those silos that we're working in, not helpful, because we should be partnering, with the Carl Harts of the universe, and we should be partnering with the National Advocates for Pregnant Women, and we should be partnering with the harm reduction folks, and we should be partnering with the homeless folks to really get at this criminalization is not working. So what are the ways in which, what are the programs that we can be using to really test, how we can reduce our jail populations? I would like to see them abolished and eliminated, but that's a whole other discussion. But at least for pregnant capable folks, for gender nonconforming folks, how can we really think about community-based programming that will, again, really allow people to optimize their reproductive life course and also be able to just sort of really meet them where they are in their lives? I think that is a crucial topic. And there are a lot of good people who are doing work on this, but the criminalization of pregnant people because of substance use just needs to stop. And there is parts in the Omnibus around not only substance use treatment, but also capacity for coaching and peer-to-peer support. So almost like a group care model, but for people who have perinatal substance use. It's fascinating. If you haven't read the Omnibus bills, this is something that Lauren Underwood cares very, very deeply about and has written purposively, not from a punitive perspective into the Omnibus, but really peer-to-peers working together to really vision a new and better life and parenthood classes and all this really cool stuff. So again, that's going to be a place where you got to bring all the different constituents to the table in order to have that discussion, though. And I still think we're too siloed.
And we're in the last couple of minutes of the talk. I wonder if I think you inspire a lot of people to try to consider public scholarship, policy translation, getting more involved in policy. You referred to the work you did on the amicus brief for the Mississippi case. I wonder if you could just tell us briefly on the ground, what does that look like? For people who have not been involved in that kind of intervention work, what does that look like, and how could people, start to get involved in that level, for example?
Yeah. Joanne and I have discussed putting together a toolkit in terms of a sign-on, developing a VAMICI, how the whole process works. And I know we're short on time, so I'll just say this relatively quickly. Depending on who is representing the plaintiffs in the case, they will arrange for pro bono law support from law firms to be able to help work with whoever is making the arguments in the brief. So in this case, the Center for Reproductive Rights took up the case on behalf of Jackson Women's Health against Dobbs in Mississippi. And I literally wrote an email to Hillary Schellner and the folks who I know are interested in nursing and nursing workforce issues. I said, hey, is APHA signing on? Is nursing signing on? And is anybody making a human rights argument? And Hillary wrote me back and said, ACOG is going to do a similar brief that they're going to lead one like they did in Louisiana. So APHA will probably sign on, and the American Academy of Nursing and ANA will probably sign on to that. And oh, by the way, for the first time ever, there is going to be a human rights argument made, and Joya Crear-Perry is leading that brief. Do you want to sign on to that with her? I said, let me text her right now, because yes, we're going to be on that. And then we work back and forth to really word that brief. And then the pro bono law firm, they do all the legal stuff, right? They get it printed, they make sure it gets filed, they do that. So it's a very straightforward process. It's just that it's not been outlined for researchers to understand, because I got to say to Julia, that's not what the evidence says. We actually really need to be making this evidence-based argument in the brief, right? Once you're on board to help start an amicus brief, you get to see the other briefs so that you can cross-reference them and use them as evidence as well. So if you want to tell a cogent narrative in a law case, leading an amicus or signing on to an amicus is an easy way to see what those arguments are, what evidence is being used that the court will be able to see, and to really be thinking about your own work and how it potentially might be used or could be used to really make good policy.
Excellent. Well, thank you so much, Dr. McLemore. We are at time. Thank you so much for joining our institute in the grand rounds and for sharing such important and informative research with us.
Well, thank you for facilitating the discussion, and thank you for having me.
Take care, everyone. Thank you.
Bye, everyone.